name's Dr Len D'Cruz. I work as a general dental practitioner in North East London with Green and with the dental care. I also work part-time as a dental legal advisor for dental protection and have done so for the last 15 to 16 years. I also work as a dental tutor for the East of England Deanery. I also am a lead lecturer for the postgraduate certificate in dental law and ethics at the University of Bedfordshire. Young dentists are facing more litigation, partly because they have less clinical experience because of the lack of experience they have as undergraduates. They come out into an environment where there's more complex needs, more complex treatment, and also patients are acting as consumers more than patients than they ever were before. The real risk also is that patients are now paying ever increasing amounts of money, and in that environment the expectations increase dramatically. We also have a situation where the lawyers have the patient's lawyers have a different system and a no-win, no-fee system. It's likely to change the environment, but that's likely to change in the future. The trend in England is likely to decrease, partly because of the change in the legal situation. There's something called LASPO, the Legal Aid and Sentencing and Punishment of Offenders Act 2012, and that has changed dramatically the issue about the no-win, no-fee. So we're likely to see over the next couple of years a change in that environment. So claims ought to be going down in the next few years, certainly in England, since that act has taken effect. The picture as far as the regulator is concerned, the GDC, that is slightly different. Whilst we might expect that claims may change in England and reduce, the issue surrounding the GDC may either stay the same or possibly increase. At the moment, there's been an increase over the last 2-3 years with a 100% increase in fitness to practice cases going through, but with the introduction in the next year or so of case examiners, that may change. I'm not very sure whether it's going to increase or stay the same, and we'll watch this space to see what happens. What the young dentist has to do is practice in a safe environment and control those variables. The real variables that contribute to risk are lack of time and lack of experience, and also having a poor team. If you can control all those three variables, then you'll have a better chance of taking risks, but actually getting better rewards for those risks that you take, which are going to be controlled risks. Go at your own pace. It is sometimes very tempting to follow what other people are doing, particularly your peers, particularly on Facebook, and you feel there's a race to catch up with other people. My strong advice would be to go at your own pace. Find your own reason for doing things, find a rationale for doing things, and go at your own pace. Pick the things you want to do, enjoy them, and find your own route to that success. We found that there is an age distribution in claims. There's a classic bell curve which peaks around 35 to 45, so it increases at a younger age and then tails off again at the higher age group. We believe that it has a lot to do with workload, it has a lot to do with expectations, dentist expectations of their earnings, and also a certain amount of complacency as they carry on their dentistry. The other issue we think that is quite important is a lack of CPD, and certainly face-to-face CPD, where older dentists rely on magazines, journals, and lose that face-to-face contact from CPD. It's that skill set from that education that they lose that increases their risk for claims. The components of a good record certainly have changed in my practicing career. What passed for good record maybe 10 or 15 years ago certainly doesn't reach any standards now. The important thing about good record keeping is having a system and essentially doing the basics right. So writing the essential things, whether it's medical history or pain history, getting those things right first of all. The other thing that's really important is when you have a challenging situation, a challenging patient, your record keeping needs to be increased dramatically for what we describe as risk record keeping. That's when you move away from the routine systematic records that you may have and move to a different plane, because you recognize there is a high risk of litigation, complaints, claims either from the patient themselves or from the regulators. So risk record keeping. So when you have a challenging complex situation, when you have a challenging patient who doesn't appear to be complying with you or listening to you, that's when your record keeping needs to be considerably better. In order to make record keeping more effective, I would recommend using custom screens, particularly computerized. These are excellent checklists that you can pre-prepare and populate as you treat the patient. So, for example, pain patients or provision of root canal treatment or crowns, if you have a custom screen with a checklist, it means that you won't miss things out and ensure that all the details are there in a quick and efficient way. I'd recommend that you use a checklist rather than a pre-populated custom screen, because there's a great temptation to leave those items on and forget to cross them off. So it's best if you actually have a checklist which you add to rather than remove later on. The key documents to read in relation to record keeping is the CQC guidance and also the clinical record keeping guidance. These are absolutely essential if you're going to know anything about record keeping. The other essential read will be the GDC standards guidance, which also has very clear guidance on record keeping, recording of records, the storage of records, and the retrieval of those records, also in relation to confidentiality. The most important aspect is making sure the patient understands exactly what you're about to do. Consent is a process, not a one-off event. Often people believe that simply signing a form at the end of treatment or before treatment starts is effectively the consent. But you have to realize that consent is an ongoing process, and it's often nuanced by the language the patient understands and also the dentist delivers. And that the real challenge for us is to make sure that patients understand what we say to them. So it's a question of delivering it in easy chunks, but also to make sure the patient understands. And sometimes you may very well ask the patient questions to ensure they actually understand the information you give them. Giving them an opportunity to ask questions, but also very clearly giving them written information. The real issue about consent is partly what they hear in the surgery, partly what they think about and reflect with you, but more importantly, information they take home with them in a written format so they can consider it at a later stage. The other thing about consent I think is important is when you have the opportunity to give them a cooling off period. That may not be possible if you are doing emergency treatment like root canal treatment, but when you're doing more complex treatment like implants, orthodontics, or even crown and bridge work, giving them an opportunity to cool off, think about the treatment you're offering them, and giving them a chance to weigh the risks and benefits of their treatment as well as the costs, and gives them, makes the consent process a lot clearer and a lot manageable, so they don't feel like they're pressurized into having treatment against their will. The NHS contract reform pilots that are currently taking place and have been since September 2011 are moving into a different phase. The next phase is prototypes, and the government Department of Health are currently negotiating with the BDA the format of those prototypes. The intention is that those prototypes will be issued in about January and go live in about autumn 2015. The likelihood of the contract is going to be a blended contract, and what the prototypes will review is the different percentages. Those three areas of being capitation, quality and activity, and it's the different blends that those prototypes will consider and reflect on over the next year. The likelihood is the earliest the contract is going to come in is about April 2017, so we've got a number of years still to go with the pilots. As far as the future of NHS dentistry is concerned, I have great hopes for it if it's based on the pilots. The essential premise of the pilot was that it was prevention based, moving away from activity, we are dealing with two essentially preventable diseases, caries and periodontal disease, and if we manage to realign the contract into prevention, it'll be a very successful contract. My concern, however, is when we come to incorporating activity, as it's likely to include with the Department of Health wanting some measures like activity, we may change the real imperative of the contract. So whilst I'm very hopeful for NHS dentistry, the actual reality will be tempered by what the actual contract turns out.